Okay, good morning, Carol. How are you?
Good morning, Annette. Nice to see you.
Very nice to see you. I know we email each other a lot, but we don't really get on Zoom much. So I thank you for your time. And I wanted to introduce Carol Petersen, who is, I was going to say nationally recognized, but you're really internationally recognized. You're on a lot of committees. And you're recognized as a compound pharmacist and an expert in bioidentical hormone therapy and with decades of clinical experience. And Carol has served in leadership roles with major organizations like the American Pharmacists Association and the International College of Integrative Medicine, and has contributed extensively to advancing education around hormone health and integrative care. And you are the founder of the Wellness by Design project. And Carol is known for translating the complex science into practical insights, especially when it comes to progesterone, therapeutic progesterone therapy, stress physiology, and the role of hormones play in overall health. So, with that, and you also have been a colleague of Dr. Platt's for many, many years. How did you guys meet initially? Was it like on
Well,
the speaker circuit?
well, that was kind of interesting because I saw somebody reading Dr. Platt's book at a conference,
Mm-hmm.
and I hadn't heard of it before. So I went and looked it up, and I bought it, and I read it. I go, oh, this is interesting, because
Mm-hmm.
he did a pretty good job with that book.
Are we talking about
And
the adrenaline dominance book?
know his
Oh,
previous book about
oh,
natural.
The Miracle of Bioidentical Hormones. Got it.
Yes,
Okay.
yes. And I thought that was quite interesting. And
Mhm.
it wasn't long before I did go to a conference in Las Vegas, and it was a big hormone conference that I think Jonathan Wright was a big participant in that. Well, I
Mhm.
happened to be in the exhibit hall, and I hear somebody talking to one of the vendors and saying, "Well, I'm Dr. Platt, and I wrote a book on hormones."
Right, right. Okay.
Otherwise, I would have never
Right.
known what he looked like or
Right.
anything. So I went right up and introduced myself, and we've been
Uh-huh.
in touch ever since.
Yes.
Quite remarkable.
Yes.
I've had meals with him, and
Yeah.
I got him to come to conference, but several times whenever I've been in the area,
Yeah.
I try to look him up and spend some time.
Yes.
Um, I think I think the adrenaline dominance book is absolutely genius.
I
Um,
do too. Yes.
I can't tell you how many times I have shared the book title with people and described what's
Mhm.
going on with that, with that reflection. And
Yeah.
it's a big piece that's missing. I was sort of horrified. I listened to a podcast with a doctor I know who's been doing bioidentical hormone stuff
Mhm.
for decades, and he presents himself as being an expert on adrenal hormones. In the course of an hour, he never once mentioned adrenaline.
Wow.
Zero.
Wow.
Zero.
Wow. Okay. Well, that's a big missing piece. I mean, that's part of the HPA axis, right?
Yeah. So my
So,
priority when I look at what's happening with people, and it sort of reflects the adrenaline dominance too,
mhm.
is insulin glucose is my priority.
Right.
The most basic hormones, the most ancient hormones, and they're strong hormones, insulin and glucose are.
Mhm.
And I'm finding so many of my clients have a problem. Dr. Ben Bickman, who has studied insulin as his career path at Brigham Young, he estimates that about 80% of the population is insulin resistant. This is a big
Wow.
driver. And so many
Wow.
practitioners, you understand that you're having some issues with your hormones,
Mhm.
but they may check estrogens and testosterone, and maybe progesterone even, but the big drivers are ignored. So when I work with somebody, I ask for a serum test, but why I want the serum test is because we can look at all the hormone systems. We can look at pituitary hormones. We can look at a complete thyroid panel. We
Mhm.
can look at the adrenal hormones and the sex hormones all in the same sample. So now you get an idea of what kind of relationships are going on.
Right.
And it's been very, very useful for me. So my priority in hormones is insulin, glucose,
Hmm.
adrenal, then thyroid, and finally sex hormones in
Right.
order of importance.
Wow. And they all show a picture on how they fit into that puzzle. And just so for the audience, in terms of the relationship between glucose and adrenaline and cortisol, like if you are under chronic stress and cortisol rises, like if you're in flight or fight, cortisol rises to produce it raises your blood sugar through gluconeogenesis, right, in the liver. So
And
that you have energy to go chase that lion or chase away from the lion or, lift that car up off the child. But if you are in chronic stress, the cortisol stops, and cortisol balances blood sugar. So if your
yep,
cortisol levels are being taxed for too long, they stop managing your blood sugar. They can't lower it. So
yep,
that's why the stress and the insulin resistance are intricately related. And through adrenaline, and then that whole process that stops. And I myself can tell you that when I first met Dr. Platt, I was hyperglycemic. And
yeah, yeah.
and I started he's like, "Let's sit down and talk." And they gave me the progesterone and I had stopped I never really understood the relationship between what I was going through. I just was plowing through. And I started using progesterone and along with his diet and started to manage my glucose levels and everything and then my adrenals started to um, be fixed, as a result over time. So,
I heard just an amazing thing yesterday I would like to share. Uh, I had a client who was a type 1 diabetic, and I was just meeting with her for the first time on a 15-minute meeting, but she had increased progesterone dramatically because of listening to one of my podcasts. And she said, let me tell you what happens to me. She said, right after ovulation, my glucose goes sky high. And she said, no amount of insulin will touch it. And she said,
really,
when I started progesterone, right after ovulation, when my symptoms start, she said, and generously, I forget how much she said she
wow,
used, she said, my blood glucose just normalized.
wow.
I think this is an important, very important clue on how important progesterone is in this whole insulin glucose thing. Following Dr. Platt's recommendations, I recommend splitting up progesterone doses, and the time to use it is
Right,
at mealtime.
right,
And so I recommend mealtime and bedtime as you're splitting those doses, because I want to take advantage of the power of progesterone for normalizing insulin glucose. As I
exactly.
said, these are such powerful drivers. That's something that can help the wild swings sometimes we get with these. It's amazing. So that's routine. I say that all the time.
Well, it's interesting because when I first met Dr. Platt, I went, why do you have on the label of your formulated cream, apply before meals? Yeah, and that seems
Mhm.
like a lot. And a lot of people go, oh my God, how am I going to remember all that? And I said, well, it's not a life sentence, but especially if you're dealing with glucose issue, an imbalance of glucose, this is really important. And most women that go through menopause seem to have that. Um,
Yes.
and
Or
why
if
is
they're
that?
symptomatic, we don't hear from the ones who don't have any trouble. So
Exactly. And so tell me why in your opinion, why do women who go through, um, I think estrogen plays a role too. If your estrogen levels drop as you're going through perimenopause and menopause. Why are women more prone to becoming insulin sensitive or insulin resistant going through menopause?
Okay, actually, correction on the perimenopause.
Hmm.
Um, Dr. Jerry Lynn Pryor has published, and she had trouble getting it published because people don't want to believe it. In the perimenopausal years, most have the highest estrogen in their whole lifespan.
Right.
And this is a bit scary because our medical systems are estrogen centric, and they think a hot flash equals not enough estrogen. No, it might be happening because of an estrogen drop. And Jerry Lynn Pryor, I just heard her speaking about this, that a drop in estrogen, which is consistent with perimenopause, that you can have some wild shifts. When estradiol drops, it starts up the stress response. So back we are to adrenaline
Hmm.
and blood glucose levels. And
Right.
so I'm so settled on this insulin glucose is a
Mhm.
big deal here, and blood glucose drops. So I had to dig a little deeper after she said that. And I said, is there a correlation on AI? Is there a correlation with a drop in estradiol, with a drop in blood glucose?
Hmm.
And as you might surmise, yes,
Right.
it will cause the same thing. So we're back to the insulin glucose issues. So
Right.
conventional medicine is, as I said, estrogen centric, and
Right.
they think in early perimenopause, when a vasomotor hot flash night sweat occurs, that means you need estrogen. That does not. That
Right.
means that means you need to look at insulin glucose. You need to look at progesterone's already becoming deficit.
Hmm.
So she's been a great mentor to me. She's also published interesting study where she had 100 women, approximately 100, 18 to 35 healthy women to go into this study, had to do something with Environment Canada, but because her whole specialty has been the menstrual cycle,
Hmm.
she had them keep records on their cycles. At the end of the study, I think it might have been as long as a year, she found that um, in 68% of those healthy young women had missed ovulations or shortened luteal phase. What does this mean? This both translates to no progesterone from the corpus luteum in the luteal phase, which should be enormous.
Hmm.
And when the luteal phase is shortened, you may have ovulated, but your ovulation does not produce progesterone like it ought to. It's a little sputter kind of response. And 68% of the women having this happen. Well, this was done during early COVID, this study. She'd done
Oh.
a previous one with 300 women. And in that group, she found about 10% of these missed ovulations short of luteal phase. And that's sort of shocking. So in general, and now we're living in a particularly stressed time. I
Right.
don't know if it was having COVID vaccine,
Hmm.
or I
Stress of it.
just the prevailing fear over
Wow.
all of this
Right.
um, can be setting this up, because what does fear do? It draws on your progesterone to make cortisol to help you cope.
Right. Exactly. So during that phase, I mean, you could connect the dots that during COVID, women were not producing enough progesterone in the luteal phase because of the stress.
Mhm.
And that's what they call the pregnenolone steal, right? In a way.
Yeah, so
Yeah.
they say, and then I came across someplace that pregnenolone was more directly helping with cortisol. Then I did a deeper
Mhm.
dive, and it says it has to go through progesterone first, and then making cortisol. It's kind of up in the air, but it makes me love pregnenolone. I also use a lot of pregnenolone
Yes,
for
right.
for my
I
my
started
clients.
taking it from listening to one of your podcasts. Yeah.
Did you?
Yeah. As I was going through a stressful situation in my life with my mom being sick and whatnot. I got a call from a customer that had been using our progesterone cream for a long time, and I mentioned this to you, but I want to share it with our listeners as well. But um, you know, in learning how, talking about the pregnenolone steal, uh, and this woman had said, I've been using your cream for a long time, but I had breakthrough bleeding and I don't understand why. And I said, let's take a step back. Have you had any stressful situations in your life or events in your life? And she said, yes, actually last month. And I go, well, is this when it happened? And she said, yes. And I said, so I explained to her that because of the stress that she was dealing with, that your adrenals were stealing the pregnenolone, which makes progesterone and estrogen as well, but it was stealing. So if you're going through a stressful response, just titrate up a little bit of the progesterone just to make sure that you
Yes.
have enough. So,
Actually, let me back up on that because
yeah.
it's a very common thing, and I want to reinforce it.
Hmm.
If you've been doing okay, and that's absolutely the right question to ask, what stress did you just have? And
Right.
inevitably it'll be something pretty big. But during this time, progesterone is no longer moderating the proliferation that estrogen causes in the endometrium. So if
Right.
you've been taking, like particularly
Right.
postmenopause, you take some of both,
Right.
everything's fine. During the time of the stress, estrogen is unburdened and
Right.
whips away growing some tissue.
Right.
By the time you actually bleed, you have gotten enough progesterone effect that the effect is it'll make that tissue secretory and shed it. So
Right.
your body's already done the correction. So you can, as you mentioned, you might want to adjust your dosing. It might be fine if this is an
Hmm.
isolated stress and it's gone.
Hmm.
You could be just fine the way you are.
Hmm.
Otherwise, you have to look at the amount of progesterone and estrogen that you're using and trying to balance it, or if your body still has plenty of estrogen. So it might mean that you need more progesterone or less estrogen or some of both, because you're kind of, if that's
Right.
happening with the stress, you don't have enough cushion.
Right. Exactly. Exactly. Well, that um, I think is really overlooked where people just feel that they're going through these events in their life and they're just going to power through it and everything will settle down. And sometimes it does, but you also have to, listen to your symptoms and understand what's happening to you environmentally and how that affects your hormones because your hormones are just constantly going up and down and up and down all the time. So,
I
uh,
wonder if I could share my slide that I wanted to bring up.
oh yeah,
Just
definitely.
do it right now. See, can you see this? Good.
Um, yes, now I can see it. Perfect.
Okay. Okay, I just made this slide for a talk
Mhm.
because this is such an important slide. People are very ignorant, and certainly your practitioners are very ignorant. Functional medicine people sometimes are ignorant. Naturopaths are ignorant because they are taught to dose in this range
Hmm.
where you get the opposite effect. In fact, there's this myth going around with about progesterone intolerance.
Right.
What happens? You get excitation, dizziness, headaches, irritability, everything gets worse. And progesterone did it. Your dose of progesterone did it. And so this is not uncommon. And ever since we've had some very low doses of progesterone available over the counter, like 20, 30 milligrams.
Hmm.
Dr. John Lee, who wrote a great book on progesterone, he really advocated this dose. And it's a problem because he maintained that your ovaries made no more than 20 milligrams of progesterone a day, and you shouldn't need any more than that. Of course, he also ignored what you put on. All of it doesn't get in to your bloodstream as you would wish. Also ignoring adrenal progesterone that's made in your mast cells and is intended to balance the estrogen in your mast cells so you don't have dumps of histamine. Progesterone is made independently in your brain. Progesterone is made by all the nerve cells, both central and your peripheral nervous system. So progesterone is made all over your body. And a lot of this does not show up on any kind of test.
Right.
So this low dose, how much is too low? Certainly these, if you don't have a great need for progesterone and you're aging gently, maybe 100, 200 milligrams of progesterone a day is fine. But when you really need progesterone, and I ask people all about, were they a colicky baby? Did they have ADHD and ADD? Did they have PCOS? Did they have painful menstrual cycles? Did they have difficulty? I think there are estrogen dominant pregnancies where women don't feel good. They're nauseous all the time. That's high estrogen. And there's a wide range of where progesterone needs to be during pregnancy. So you can have a super long history of low progesterone, and these dinky little doses are going to set some things in motion, and you're going to get actually the opposite response. You really do not want that. So my experience early on came from Katerina Dalton's work, working for a compounding pharmacy. We were doing progesterone in olive oil, orally. We were trying to duplicate Katerina Dalton's work with progesterone for PMS. She's a wonderful woman who characterized PMS, and she also thought to use progesterone. And some of her patients, she would do a serum level for progesterone in luteal phase, and they were in range. She did sort of a leap and used progesterone only. She tried it on herself first, and away it went. The symptoms resolved. So she theorized there might be some other problems, some kind of receptor resistance or carrier protein issues, not relinquishing the progesterone like it should be. We don't really know for sure. That's 50 years ago. We still don't know. But she used doses. First she used injectable progesterone, then she settled on 400 to 600 milligram suppositories, either vaginally or rectally. And we were trying to see if we can get the same results with capsules. And progesterone micronized, small particle size is essential. And then in oil, because when you put progesterone in oil or you have it with some fat in your meal, it gets absorbed like a fat. And so many people say, oh, oral's no good. It's going to break down the liver. And some of that's probably true, but a good deal of it goes into the lymphatic system and distributes throughout your body. So I don't really like using low doses. And here's where Dr. Platt, I think, does not have my experience with some very, very severe progesterone deficient women. And you really have to be on this end. So I'm looking for doses like 300, 400 milligrams to start in luteal phase, 300 milligrams every day for menopause to make sure that bone remodeling is taking place. And so I use the same doses as the oral capsules and creams. There's not an exact, exchange from one dosage form to a cream to a suppository to troches and lozenges and injectable. There's no magic guide to tell you how much of this is going to be this. And the other irony is I'm taking 200 milligrams of capsules of progesterone at bedtime. How much cream would that be? Well, the first thing I want to know is that 200 milligrams actually getting you to 100% relief of progesterone deficiency symptoms? And sometimes it's not. And I said, you want all of that gone, and you can change dosage forms. You have to just start someplace and work with the dosage form that you want to use. Let go of that now.
Yeah, I think that there are many of women who say they like the oral because it makes them sleepy, because it converts to allopregnenolone at
Mhm.
night and it stimulates the GABA receptor, so they like that. And I said, but they also want to dose before meals, and you can't take oral during the day if you wanted to manage the glucose. So they use a little combination of both. They'll use the cream, before meals, and they'll take the oral at night, or they might just, use the cream altogether. But there is a lot of talk about oral going through the liver and losing efficacy, and you say that that's not necessarily true.
No, not necessarily.
And I
I
and I
finally
have
did.
to I have to say I agree with you, because if people were just taking oral, they would, and some women feel really good on it. So how is that,
Yeah, no,
how is
it's
that really
absorbed and it's used just fine.
right? But the only
Just
thing
fine.
is you can't take it during the day.
Well, you can.
Oh, you can.
100% you can. And we had in the PMS days, severe PMS,
Mhm.
starting dose 100 milligram oral capsules 4 times a day, going up from there. And it was years before we had enough complaints about drowsiness and dizziness to even put a sticker on our bottle may
Mhm.
cause dizziness and drowsiness.
Right.
It was not all that common.
Mhm.
And so we would switch to maybe different dosage form or use smaller doses at a time to try to avoid that. Now, a few years ago, I thought to myself, wait a minute, I think this allopregnenolone is something that is a barrier to treatment with progesterone. And so,
Mhm.
like every other thing, do some women create more allopregnanolone? So you get this excessive drowsiness, dizziness, and other women do not.
Mhm.
What hangs up allopregnanolone?
Mhm.
So I went to the internet, God
Mhm.
bless it, and I found out why. And if you actually do get dizzy drowsiness, no matter what dosage form you use of progesterone, because you can, it
Mhm.
means allopregnanolone is hanging on. And women have reported to me they take a bedtime dose of progesterone, they're still groggy the next morning.
Mhm.
Um,
Yes, I hear
they
that too.
cannot sulfate or glucuronate. These are two detox pathways
Mhm.
that allopregnanolone
Right.
needs. And so now this is really cool because I say, if it comes up, I say, you need one of these. I like sulforaphane, NAC, glutathione for sulfation,
Mhm.
or simply eat 4 eggs.
Right. Well,
Lots of sulfur in there. And
and, you know,
calcium D-glucarate for
right.
getting some glucuronate there. So any of those can be used, and it's working. I have to say it's
Exactly.
working.
Well, and then, that really ties into cortisol, is that your mitochondrial health is important to cortisol production. And so if your liver or your detox pathways aren't working correctly, you're not
Mhm.
metabolizing, and you're not methylating. So that's probably the reason why some women are more affected by the oral, because they're not processing the allopregnanolone, because they
Yep,
might have detox pathways that are clogged up and that need to be.
yep.
And those women may
Need
do
to be
better
addressed.
on, right. It needs to be addressed. So it is not really a problem, but it's pointing you to something, an underlying cause that needs to be addressed.
Mhm. Yes.
And and that's why maybe some women might be better on the cream, but it's not really addressing the underlying issue, because you could be storing, more
Mhm.
progesterone or other hormones in your liver. It's not processing correctly. So that
Well,
needs.
it's just everything needs to be created and
Hmm.
metabolized down the line for excretion. And
Right.
so
Right.
that's the problem with aloe. So I thought I did a
That is
blog on
interesting.
this. I thought it's breakthrough as
That
far
is
as I'm concerned.
breakthrough. That's huge. That really is. That is.
It's huge, but
Mhm.
I haven't gotten a lot of excitement yet on it, and it's not been that long ago. But I think it's an important piece that you don't just
Yeah.
say, "Oh, well, you can't tolerate progesterone because this is happening." No, you've got a liver issue that needs to
Right.
be taken care of. So,
Exactly.
like I said, you can use these improved sulfation and glucuronidation, but your liver is struggling in general.
Right.
So you can address that.
Interesting. Very good. Very good. I know that, in the functional nutrition space, that there's a lot of talks about detox, if they, and as it relates to the hormones, and that's really, really important, especially when you embark on this new therapy and you hear how everyone, is supposed to make you feel better and you don't, it actually exacerbates your stress, and anxiety.
Yeah, and you're not being dosed appropriately. Yeah,
So
I heard one
what would
doctor
you,
saying
what,
like 10 to 20% of her patients are progesterone intolerant. No, it tells me you don't know how to dose progesterone because you could get rid of that very, very easily by giving enough.
So what would you tell if you had a client that basically was using progesterone 100 to 200 milligrams a day and they said that it was increasing their heart palpitations, their blood pressure,
Yep.
their anxiety. What would you look at and what would you explain to them on how to approach that?
I would say, just like that chart said, I need to
Hmm.
get from too low a dose for somebody to get to a higher level. I also want that dosing to be spread out through the day. Progesterone in any dosage form, except for um, maybe injectable, lasts a little bit longer, but it wears off. It's going to wear off, and you might need another dose in approximately 4 hours. Well, depending on your metabolism,
Right.
you you're giving one dose at bedtime and think it's going to last you all day.
Right.
You're
Exactly.
you're out of it. And then,
Hmm.
so I want the dosing spread apart, and each dose should take you away from anxiety to calmness. And if you need to take progesterone every 3 or 4 hours to do that, good.
Right.
What's your upper limit? No upper limit. You take what you need.
Right.
Your body desperately needs it. Those signs and symptoms are an issue. But let's go
Mhm.
to wakening during the night and can't go back to sleep.
Exactly. There you go. Perfect.
Okay. Now
Good
we're back
segue.
to
Adrenaline.
now we're now we're back to adrenaline dominance.
Right. Right.
And
Exactly.
we're back to what sets that off. That's the night sweat, a vasomotor thing. And
Hmm.
so you have a drop in glucose, and up goes your adrenaline. Bang.
Thing. And
And
because adrenaline is a precursor to raising your insulin or cortisol and insulin, right?
well, 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 cortisol, I believe cortisol is not the enemy. It's trying to balance off
Right.
that adrenaline
Right.
and may for a short time, but then you're wearing off of your ability to provide cortisol.
Right.
And so what do you do in the middle of the night when that happens? Well, about 40% of the population don't methylate very well, and you need methylation to detox adrenaline. Also could use MAO, but we don't have any supplements or um, pharmaceuticals even that provides MAO.
What's
So
MAO? Can you explain to our
monoamine
listeners what MAO is?
monoamine oxidase. Where you find some information on this is we have some drugs that are monoamine oxidase inhibitors. We don't really favor it going, but it needs to go to balance adrenaline or detoxify it. So that's kind of a big hole with not enough information.
Hmm.
And you can see on genetic tests, sometimes there will be some information about an MAO status, your ability to make it or not make it.
Hmm.
So it's an interesting piece, but
Hmm.
so it's unavailable to us. It leaves us with methylation. We've got to methylate.
Right.
And so where do you get that from? In a perfect world, actually, your gut microbiome would be making all your methylated B vitamins for you. We wouldn't have to supplement. So it points to microbiome being off. Also, it points to maybe not enough nutrients in your food because that's another source. So we support with methylated B vitamins. To
Hmm.
help methylate, we can support with betaine. Betaine is trimethylglycine. We can phosphatidylcholine turns into betaine. That's really a nice one. SAMe is sometimes used. I usually stick with the first three that I mentioned,
Nice.
and and it would be nice if it were so easy
Right.
because some people have methylation issues coming. That's MTHFR, those particular genes.
Hmm.
But there's another set, COMT, particularly important in methylating estrogen. So there may be some people with both problems,
Right.
and the solution isn't so easy. So right now I'm thinking those with the COMT issues might be able to get to it by using phosphatidylcholine safely.
Hmm.
Um, the books suggest folinic acid rather than methylfolate and
Right.
hydroxycobalamin rather than methylcobalamin for B12.
Hmm.
So I wish everything was straightforward, but it isn't because we're all
Right.
so individual.
We are
And
individual. And for those
so
people that don't know what the COMT and um,
MTHFR,
right, the MTHFR is basically a lot of people have issues with hormone therapy because they are not methylating, they're not absorbing, and
right?
you're contributing this to maybe the gut, the microbiome. Um,
The gut is an underlying problem that you
right,
ought to look at, definitely.
right.
So
So back
you
to
can
waking up in the middle of the night.
okay, so what do? You can eat
Mhm.
something.
Right.
And you can use progesterone because progesterone does have a balancing effect on adrenaline. You can take your B complex, your methylated B complex. You can exercise. Actually, exercise helps you burn up excess adrenaline.
Hmm.
But laying there, not sleeping, is not going to allow that adrenaline to be detoxed. You're better up getting up, clean your house or something till you get drowsy. But you can use all of these. You can use any one of them, or you can use all of them.
That's interesting. You know, my father's 88 years old and he has always had an issue where he wakes up in the middle of the night. He'll have like a peanut butter sandwich and a glass of milk, or he'll start reading and he'll do things around the house until he gets tired. That's exactly what my
That's
dad has
ex
done. That's exactly what he's done. That's
I know,
really
isn't that
interesting.
amazing? Because
Yeah,
there are there are people that find solutions. They automatically find works for them,
right,
and they do that.
right.
It's absolutely beautiful.
Can I just
So
point out a little bit
here,
about the meal plan that Dr. Platt talks about in his Adrenaline Dominance book? And I have recommended this to a lot of our customers, including myself, and it works about 99% of the time for me. And that is, you know, your brain requests fuel in the middle of the night because cortisol levels are up. And maybe that's because we're dreaming and our brain is, you know, just active. I'm not sure, but or maybe it's just a cyclical thing with the rhythms, the circadian rhythms where it goes up and down. I don't know what your thoughts are, but the I would take like if I made green beans for dinner, I'd take a quarter cup aside and I would put some coconut oil on. I know Dr. Platt likes MCT oil, but that irritates my gut, so I just use regular MCT oil. And so that fuels that gives my body enough nutrients and fuel for when my brain requests glucose in the middle of the night, it doesn't have to raise adrenaline as much to get that
right.
to raise the blood
Right.
sugar
You
up.
you
So,
you've helped your glucose be stable.
right,
But you also have to look at underlying this is also a liver issue.
it
Your
is.
liver
Yeah.
stores glucose as glycogen, and you have
Mhm.
not stored enough glycogen for the night. So back we are to look at how you support
Right.
the liver. In the 1930s, there were some amazing endocrinologists who would recommend that you put an apple at the side of your bed. And when
Right.
you woke up, you ate
Right.
the apple
Right.
and you ought to be going back to sleep. But the apple provided some instant glucose, but it also supplies some fiber, which will slow up the
Mm,
drop in glucose again. And so they called it liver insomnia
interesting.
because that was the
Interesting.
underlying principle, not enough glycogen stored by the liver. Something else to look at in some individuals, like you're running short of cortisol, so you pull out all the progesterone to make more, you pull out all the allopregnenolone, and
Mhm.
you're pulling on cholesterol. And there are individuals who have their total cholesterol is way too low.
Mhm.
And here
Right.
again is a liver issue. Your liver makes 90% of the cholesterol. So the best levels are 220 to 280.
Mm.
If if you're falling
Yeah.
under that. And it came to my attention. I had like 6 clients in a row. It was like the
Mhm.
universe slapping me. What their total cholesterols were 86 to 130.
Oh my
The
gosh.
one
So they're not producing any hormones.
exactly, you can't make it. You can't make
Wow.
those hormones.
Wow.
So now we have tests. The total cholesterol, the test acceptable range will say under 200.
Right.
So these severely deficient people are not identified. In fact, the doctors will say, oh, this looks wonderful. You get to 201 and you get red flags all over your
They
test.
want to put you
No.
immediately on cholesterol medication that
Yeah.
causes
And
dementia and all those side effects.
you 100% don't need to medicate your cholesterol. You need to
Right.
support it.
Right.
Support your liver if you're not making enough.
Mhm.
And the normal ranges used to go all the way up to 350. When you make a lab range, when the lab does it, they're required to choose a cohort of healthy, we hope, people,
Mhm. Right.
and they will actually get called a Gaussian curve. Like some people have this amount and it rises, more people in the middle, and then it tapers off. So this is the range. They make the range, but
Interesting.
the ideal is in the center of the range. Now, we used to have that for human beings, but now by committee, medical
Mm.
groups have gotten a few so-called experts, probably funded by pharma,
Hmm.
to say, no, we want our range to be lower.
Right.
This is not science.
Right.
Uh, the
Right.
the
Wow.
original thing is correct. So for a lot of our lab tests, we do have correct ranges, but not for that one. They've altered it.
Wow. That is incredible. I know that my cholesterol is high. It's more in the upward of 280. And my doctor wanted to put me on what is it called? Lipitor.
Yeah.
And I
No,
said,
no, no, you're perfect.
no, no, no. I said, absolutely not. It causes, dementia, like early dementia symptoms.
Yep.
Terrible, terrible. And I've taken measures to help my family understand that as well. So I know that I wanted to kind of wrap it up. I know I had a lot of questions, but I think that we've gotten really to the core issue here, and that is, what would you tell a woman who's either embarking on hormone therapy or is having these progesterone intolerant symptoms? What would you do as far as a health coach to address their liver issue? What would be like your first step to have them, would it
You
be like
could
a liver detox or?
you could do a liver detox.
Mhm.
Sometimes I recommend that, or it could be just as simple as one of the nicest herbal things is like milk thistles to support your
Mhm,
liver.
mhm,
Um, Also, keep away things that are not in the natural world away from your liver. You know, when you eat things or you put things on your skin that don't belong in your body, you
mhm,
stress the liver enormously. So that's really the first step. Get the toxins away from your body as much as
mhm.
you can. And there are a lot of things you can change in that regard, both your diet, the food intake, quality of food,
Right,
all of that pays, and being exposed to toxins, choose cleaning things that aren't toxic to your body. So
right,
all those things will remove a big burden from the liver and allow your liver to start working the way it should be.
right. Right. I think this podcast should be more about supporting the liver than anything. But
Just
this just tells you how it is so important for people to really take into consideration their environment, their diet, and your hormones, and you can't just take, I know that a lot of people in our fast-paced environment just want to take a pill and move on and feel better, but it doesn't work that way. And I know that a lot of our clients say, oh, well, I've been on, this or that for 2 weeks and I don't feel any different, or they may have some side effects. And I'm like, well, these side effects are pointing to an underlying issue. So no matter what cream or what form you're going to take, you're still going to have those issues. So, it is so important to really understand, once you start changing your health routine, it does reveal sometimes the underlying effects that you have to address. So,
absolutely.
right,
So
absolutely.
one of the really lovely things about just as you have made progesterone and other hormones, DHEA and estrogen, pregnenolone, etc.,
Mhm,
all all being available for the public, and we also have direct to consumer lab tests that you can do.
mhm.
And so it's an opportunity for people to really start paying attention to their bodies. The only person that really cares about you is you in the end. And it really, we have kept ourselves ignorant all the way through our training and what makes a healthy body. And I'm sorry, you're going to have to do some homework and learn
Mhm.
how your body works. And I guess that's why we're here, in that you need to know how your body works and what changes you can make. You become the scientist. It's an N of one study. It is true scientific method by
Right.
using some things, adjusting, um, and that's what has to happen, and
Right.
it is happening. So all those people that are calling you, Annette, they're in that
Yeah.
process,
They are in that
and
process, and it's difficult because we're not hormone coaching here, which is why I want to bring in experts like yourself to help educate our customers on pointing them in the right direction to because basically we have the supplements, we have the hormone creams, but unless you really know your body and you're listening to your symptoms and you're addressing your gut and liver issues and your environment, it's not going to work. It's just, you're going to get and I think with women who seem to balance their family and life and they're just so used to powering through, you can't really power through this. You have to really understand the balance of your hormones and your diet, and adrenaline is a big one. And I know that I was reading real quick, and I just wanted to ask you real quick. Um, High cortisol levels will indicate a lower DHEA. Is that true? So if somebody before they start taking DHEA, should they have, their labs done to see where they're at? No?
no, no, but you can just consider. Here's another lab issue. So
Yeah.
consider your DHEA levels, the steroid hormone, like all these hormones we're talking about, your body makes the most of DHEA. And I'm glad you brought it up because we're kind of ignoring DHEA. Remember, DHEA was up there with my second level, the
Yes,
adrenal hormones.
right.
So your adrenal glands are making this, and it's a steady downward cascade as you age. So by the time you're 80, you're at 20% of what you made in your 20s.
Okay,
And it's a foundational hormone. It's precursor to estrogens and testosterone.
right.
It's a bit anabolic. It's restoring, you're rebuilding your tissue with all of this. So I look at DHEA a lot for people, and it could be quite low. But what they've done is they used to give you a DHEA level, and they would show you a range for each decade of life.
Hmm.
And now what they do is they have what your birthday is, so they'll give you your age appropriate range,
Wow.
which has been done on people who have declining DHEA. So your goal would be like you would like to be in the 20 to 30-year-old level, but you don't have that information with that test. So you have to look it up on your own or have somebody tell you that you can be much higher. But I see some very low DHEA levels, and it makes a big difference when that comes up appropriately. It's got more to do with female libido than testosterone does.
Interesting.
And then one of my clients really surprised me. She got to 35 milligrams of DHEA, and she takes it at bedtime.
Hmm.
I never thought of DHEA helping sleep, but she already has some help with progesterone that she was using. She said, my sleep has become profoundly deeper by
Wow.
using DHEA at bedtime. I'm not giving it up, she says.
Now, so if someone were to buy, like, say, a 25 milligram, if they're like in their 50 or 60 range, you can basically safely say that their DHE levels are low.
Yeah, definitely.
And
You
why?
can measure it as well, but you might as well,
Yeah.
you can also assume. A
Hmm.
DHEA, the only time it goes up is there's a situation. It's analogous to PCOS with the ovaries. Okay, so you're actually LH stimulates the ovaries, and you're not making progesterone out of it, but you can make testosterone. So testosterone surges.
Hmm.
In the case of the adrenals, ACTH is stimulating the adrenals,
Hmm.
and it is not making enough cortisol out of that stimulus, but making a lot of DHEA. So in both cases, progesterone can be used because progesterone is a precursor for cortisol that you have low.
Hmm.
So once in a while that comes up. So if somebody's highly androgenic looking with facial hair and hairy parts. Oh, and DHEA, the hair on your legs, lower legs, if
Hmm.
that's gone, that's low DHEA. Losing hair on your armpits, low DHEA.
Interesting. Very interesting. So in some cases, I know that there's some women, or they talk about, like, I didn't do well in DHEA. That would really fall into the category where they're not producing uh, enough testosterone. I was a little unclear about how you described
Oh,
that with the
so
LH.
okay, so that was PCOS.
PCOS. Okay, right.
Polycystic ovary
Okay,
disease, when you get high testosterone levels, but
right,
progesterone doesn't happen. These women
right,
skip periods,
right.
or if they hit, it's just very low, and that's the key to flipping that around is put progesterone back in.
Great, great. So they're good bedfellows, the progesterone and the DHEA, especially if you have PCOS.
But
So
if you have
yeah,
PCOS
yeah,
symptoms, you
yeah,
should find out if you
yeah.
have high testosterone, or you should find out if you have high DHEA too.
Right, right. Very
But
good.
that usually occurs in younger women.
Right, right. Okay, well, so the takeaway here for the listeners, Carol, unless there's something else you wanted to add, but I think we covered quite a bit of topic when
Oh,
it
yeah, we did.
yeah, we did. We really did, and it was really great. So the relationship between progesterone and adrenaline, is very crucial in terms of helping manage adrenaline and your stress. And
Yes.
and as far as dosing out throughout the day, you say it's really good for people that may have excess adrenaline. Um,
Mhm.
but also helpful just to have it in your system all throughout the day, because as you said, if you're just taking it at night, then you don't really have all the benefits of the progesterone cream during the day. So whether or not you're
Exactly.
having insulin issues or glucose issues or adrenaline issues, you say taking progesterone throughout the day is beneficial. Is that correct?
That's correct.
Okay, okay. And low doses are not necessarily, they so as far as like I know that you have to talk about symptoms and titrate up as much as possible. And I know that a lot of women think like 100 or 200 milligrams a day is sufficient. But if they are not, if you're going through menopause,
For a
that's
lot of
just a
women, I have
minimum.
no idea. And if it puts you smack in that low dose part of my curve, you're
Hmm.
going to suffer and you're not going to like progesterone and
Right,
you're going to hate the doctor who gave it to you.
right,
And you're going to
exactly.
hate progesterone and you're going to be scared to try it again. So
Right.
it's a big disservice to women. So
Now,
I never start low, never with progesterone.
now let me ask you, I
None
heard,
of this start low
yeah,
and go slow has been taught to people, never
right,
with progesterone.
interesting. Now, I just wanted to spell, I heard this in some circles on Facebook that they feel that um 20 like not necessarily high doses at one time are going to be beneficial because they feel like it overwhelms your receptors. What do you think about that? Is that a myth?
Yep, I don't know who would have measured that. I don't know.
Yeah. Or they might take
That's
800 milligrams a day,
okay.
but they say,
Realize this. Okay, realize this. This is not a permanent relationship.
hmm,
Receptors and the hormone that hits it. It's a hit, turn things into motion, and away you go.
right, got it. And then, so once it hits into the receptors, are you saying it goes into your tissues and starts doing the magic?
Yeah.
So,
So right, right.
right,
It sets all the physiologic things that we know are mediated by progesterone go into effect. And
right,
it's not that receptor just sitting, clinging to progesterone
right,
forever. It's a hit
right.
and
And then
away you
gone.
go.
Right.
Mhm.
Which maybe next time we can talk about lab testing.
Okay.
I actually have a blog that you guest blogged on our website, and if anybody, I'll drop it in the link on this YouTube channel so you can read more about lab testing and whatnot. But Carol, I want to thank you so very, very much. This was really, really, really helpful. And also, I hope that you join us again soon. So I want you to wish you a very have a great rest of your day. And thank you again for joining us. This is really great.
Thank you. It's my pleasure. And it's so important this information gets spread because it really can make an amazing difference to quality of life.
Absolutely.
Probably length of life too. I don't know.
Well, I think in particularly we need this now more than ever with the amount of stress that's happening in the world today. So thank you,
Yes, for sure.
Carol. Have a great day. All right.
Thank you.
Bye-bye.
Bye.